Okay. I don't have the screen here, but okay, I'll start anyway. Assalamualaikum and a very good evening to everybody who's watching this webinar. This is the Aspen sponsored webinar titled Central Neuraxial Blockade in 21st Century, How, When and Why by our esteemed speaker, Professor Ki-Jinn from Department of Anesthesiology and Pain Medicine, Toronto Western Hospital and University of Toronto. I made Professor Chin's acquaintance somewhere in 2012. I think we were co-speakers in the International Symposium of Spinal and Paraspinal Sonography in Hong Kong. He is currently the world authority in erector spinal pain block as well as spinal sonography. And it is now, I think, timely for us to understand where we are heading with the central neuraxial blockade, particularly with the advent of newer blockades, neuroparaspinal blockades, for example, ESP, as well as a lot of the abdominal wall blocks, particularly quadratus lumborum and things like that. I think this is something, an important issue. Where do we place central neuraxial block in our current practice at the moment? I think with that, I wouldn't waste too much time. I would like to invite Professor Chin to actually deliver his talk on central neuraxial blockade in the 21st century. Professor Chin.
Thank you, Shah. Thanks very much for that kind introduction. And I certainly remember going to ISPS in Hong Kong, which was a great conference. And, you know, and acknowledge people like Manoj Kamarka, who really laid the groundwork for everything that we've done and known about spinal ultrasound. I'd also like to thank Aspen for their generous support of this webinar and for supporting regional anesthesia, particularly Malaysia. I understand they are great investors in education, and that's really valuable in this current setting. So it's a great privilege for me to be able to speak to all of you this evening on the topic of central neuraxial blockade and where it stands in the 21st century, particularly because, as some of you may know, I have roots in your close neighbor, Singapore. But in addition, I also have a Malaysian connection through my father, who is a Penang boy and was a former head prefect at Penang Free School. And he himself is a physician and radiologist, actually. So perhaps my interest in ultrasound was not an accidental one. And I believe he's watching this, so I would like to take the opportunity to thank him for inspiring and supporting me all of these years. The focus for this evening is going to be neuraxial blockade, or spinal and epidural anesthesia. And spinal anesthesia was really the first regional anesthetic technique to enter mainstream practice, followed closely by epidural anesthesia. And both of these remain core skills for all anesthesiologists up to this day. At the same time, as Shah has said, we've seen tremendous advances in regional anesthesia. We've seen a resurgence of interest in peripheral nerve block techniques with ultrasound, and also with the development of these new fascial plane blocks. So it's not surprising that we're starting to question perhaps how common and really what the place is of neuraxial blockade is in our modern anesthetic practice. But these are the advantages of neuraxial blockade over general anesthesia that our trainees are taught to spell out when they're discussing the options with patients. And I will say that the one that I often caution trainees against overstating is this recovery after a general anesthetic, because with modern volatile agents such as sevoflurane, desflurane, short-acting opioids such as remifentanil, recovery is extremely rapid. And you only have to look at the thousands of day surgery general anesthetics that we administer every day. Even nausea and vomiting, which is one of the side effects of a general anesthetic, is preventable with appropriate chemoprophylaxis and a total intravenous anesthetic. So I think the risk is much lower than we tend to emphasize. But when it comes to neuraxial blockade, the advantages that are most compelling for me are the predictable physiological effect. In most instances, we're able to provide a simple and stable intraoperative and recovery phase of anesthesia. And the physiological change is a one-dimensional one. We get vasodilatation of the lower torso and legs, and yes, it produces a degree of hypotension, but we have a very efficient treatment as well, which just gives some vasopressors. And I think that's why many of us intuitively prefer a spinal anesthetic in somebody who has complex cardiac or pulmonary issues. In addition, in this era of COVID, with the concerns over aerosol generating medical procedures, avoiding airway management has gained a lot of importance. And so I think this is currently one of the most popular reasons that we should consider neuraxial blockade over general anesthesia wherever possible. Having said all of that, neuraxial blockade also has its own set of adverse effects and limitations that we must consider. Fortunately, all of these serious complications are very rare and can be avoided with proper patient selection. Posterior puncture headache is something that's often talked about, but it's very rare if we're using small gauge needles, and especially if we're using pencil point tips rather than Quincke tips. Another potential adverse effect that's sometimes overlooked is transient neurologic syndrome, also known as transient radicular irritation. And I think this is perhaps becoming more relevant as we see a move towards more day surgery spinals and the use of short-acting local anesthetics. I would say that transient radicular irritation is probably a better name, as there are no actual neurological deficits associated with the syndrome. It typically will resolve within 2 to 5 days, but during that time, it's characterized by moderate to severe pain that's usually burning in nature and located in the lower back, buttocks, and thighs. So you can see why some patients might find it concerning after they've had a spinal anesthetic. Nevertheless, you should reassure them that it's relatively harmless and will resolve. As I've said, it's most commonly associated with short-acting local anesthetics, especially lidocaine, with the risk thought to be somewhat similar to the other local anesthetics like mepivacaine and chloroprocaine. I will say that there isn't a huge amount of data, and in our hospital, we certainly use mepivacaine as our short-acting local anesthetic of choice because we believe that the risk is lower compared to lidocaine, and I must say that we very rarely see it in our practice. If you want to avoid it, however, then the choice should really be bupivacaine, ropivacaine, and prilocaine, with which it's a very, very rare occurrence. Now, the reported incidence does vary widely, and this is because there are also other contributory factors, the most important of which appears to be surgical position, with the lithotomy position being most strongly associated with the risk of TRI. So I personally would always use bupivacaine in this setting. Now, another adverse effect that can be overlooked from spinal anesthesia, mainly because it occurs after we hand over care to the PSU, is the one of urinary retention, which can require catheterization or delayed discharge from the day surgery unit. This is one of the few outcomes for which general anesthesia has a clear advantage over spinal anesthesia. Overdistension of the bladder during the period of the parasympathetic block causes this transient detrusor muscle dysfunction and an inability to void even after the spinal anesthetic is resolved. There are, however, some steps that we can take to minimize this risk. Generally avoid bladder distension by encouraging the patient to go to the bathroom before entering the operating room, by limiting the amount of fluid that's given if possible, and trying to match the duration of spinal anesthesia to the duration of surgery. There may also be a role for the prophylactic use of a drug called bethane-chol, which is a cholinergic agonist that's used to treat detrusor underactivity in elderly patients. But finally, modern surgical practice is also very much about enhanced recovery and fast-track pathways and same-day discharge. And for patients who ambulate or do physiotherapy, we have to see a complete resolution of the motor and sensory blockade, which can be a lot longer than the duration of surgery. And this will obviously delay early mobilization and same-day discharge. So this is one of the big issues that people struggle with when deciding whether to perform spinal anesthetics in a day surgery setting. Given all of that, you might be wondering, therefore, what are the compelling reasons to routinely perform neuraxial blockades in your practice? Well, I'm going to highlight several areas that apply to modern anesthesia where I think it does offer a lot of potential value. Now, the first area is pediatric anesthesia, where I confess that I personally don't have a lot of experience or expertise, as I deal mainly with adults. But I recommend this excellent review to you, which was published earlier this year in the journal Anesthesia, and it's part of a free-to-access supplement on regional anesthesia. The authors highlight the concern that has arisen regarding the potential central neurotoxic effects of general anesthesia on the developing brain. And animal studies have shown that exposure to volatile anesthetics can cause neuronal apoptosis and behavioral changes. And they seem to do this by directly activating the mitochondrial apoptosis pathway and causing excessive calcium ion influx and release, which overload and damage neuronal mitochondria. At the same time, though, I have to emphasize that a large multi-center RCT has shown that this doesn't appear to be an issue with single short-duration general anesthetics. And there was no difference in detectable cognitive function at ages 2 to 5 if infants received either general or regional anesthesia. However, the preclinical data indicates that this neuroapoptosis is dose and time dependent, and therefore it may actually be a potential concern still in very young children who undergo repeated or prolonged anesthetics, with one definition of prolonged duration as anything more than 3 hours. One could also ask if there are more subtle learning or cognitive deficits that were not picked up by the assessment tool used in this RCT, or that would manifest later on in life beyond the age of 5. So given these concerns, there's been renewed interest in spinal anesthesia as an alternative in infants. Spinal anesthesia is actually very safe in this group, as their sympathetic nervous system is not fully developed, and thus it's rare to see hypotension. Respiratory compromise from an excessively high block is a concern, but it is uncommon if you use appropriate dosing. In fact, the data suggests that these patients often don't even need supplemental oxygen. It's further helped by the fact that they don't even need supplemental sedation, most of them sleeping peacefully through the procedure. And the most common applications are obviously going to be lower abdominal and lower limb surgeries. The authors do note that in general, the duration of surgery is limited to less than 60 minutes, which somewhat negates the benefit of a general anesthetic. But they do describe the use of combined spinal caudal techniques if you want to do more prolonged surgery. I would say probably the main obstacle to infant spinal anesthesia is provider anxiety regarding the level of skill that is required for spinal anesthesia in such small people. And I confess that I would be pretty anxious myself if I was asked to do this on just an occasional basis. And so for this reason, I think it may remain a technique for now that's utilized primarily in tertiary pediatric centers. Now, some of you are probably wondering then if the same concerns regarding general anesthesia and cognitive function apply to the older adult. So again, preclinical studies in animals have found an association between volatile anesthetics and the accumulation of amyloid beta protein in brain tissue, which produces a pathological picture similar to Alzheimer's disease. The good news is that this has not been observed so far in human subjects, and there is currently no good evidence for any association between dementia and exposure to surgery or anesthesia. But if we look not at the instance of dementia, but at this normal longitudinal decline in cognition that occurs as we age, then what's been noticed is that exposure to anesthesia and surgery is associated with an acceleration in the rate of decline. And this is indicated by both the red and dotted lines in this graph, with the red indicating prior exposure before the study started and the dotted line exposure after enrollment in the study. And this acceleration is seen regardless of the patient's existing baseline health and cognitive function. Now, in the subsequent study, the same group who reported this compared the rate of decline in patients who received either general or regional anesthesia. And what they found was that both modalities accelerated the declines in global cognition to an equal extent compared to no anesthesia. But when they looked at specific cognitive domains, both modalities were associated with a decline in attention and executive function. But in terms of memory, there was a greater decline in memory function in patients who received general anesthesia. What about the more acute problem of postoperative delirium? Now here again, no difference has yet been demonstrated between general and regional anesthesia. And it appears that perhaps the main driver is your baseline mental and physical status. And this, for me, was best illustrated by a study of depth of sedation in hip fracture patients who are undergoing spinal anesthesia. Although they didn't find an overall difference, when they took patients' state of health into account, as measured by a comorbidity index, they observed that lighter sedation did actually lower the risk of delirium in the healthiest group of patients, and that there was actually a rising risk of delirium with increasing comorbidity in that group with light sedation. If you give everybody deep sedation, on the other hand, then that seems to even out the risk regardless of the patient's health. So to me, this is a suggestion that we should be avoiding general anesthesia if possible, and certainly minimizing depth of sedation, particularly if we're dealing with healthy elderly patients who have normal brain function. Paradoxically, patients who already have some degree of dementia are going to be at greater risk of delirium anyway, and then the level of sedation may make little difference to the actual risk. Now, the second area then I want to discuss is related to cancer, which is a very common indication for surgery. And what has become evident is that even if you undergo the most successful resection surgery with histologically clear margins, it always leaves behind minimal residual disease. And this is due to the fact that there are micrometastases, either pre-existing or from embolization at the time of surgery. And whether or not these develop into clinically significant tumors depends on the balance between immune-mediated destruction of the cancer cells and the tendency of these cells to want to proliferate and establish a blood supply. And it's been increasingly recognized that we, as anesthesiologists, can potentially influence this process with our perioperative management of patients undergoing surgery. And this gives us a very important role then in determining the long-term outcome of cancer patients. This has led to the emergence of onco-anesthesia as a subspecialty, and another good overview is provided by this article in the 2021 Anesthesia Supplement. It nicely summarizes the mechanistic basis for onco-anesthesia and describes the contributions that regional anesthesia can make to the outcomes. This figure from the article summarizes the various mechanisms for the pro-metastatic effect of surgery, and it illustrates where regional anesthesia can have an effect. And this includes attenuating the surgical stress response, attenuating inflammation, and acute pain. Regional anesthesia also allows us to minimize the use of opioids and volatile anesthetics, which have been shown again in preclinical studies to promote tumor cell growth. Now, unfortunately, the evidence from clinical trials does not as yet show a clear benefit from incorporating regional anesthesia. And this is probably because prognosis in cancer is dependent upon so many other factors, not to mention the fact that different tumor cell lines respond differently to drugs. However, I would bear in mind that there is absolutely no evidence as yet that the use of local anesthetics or regional anesthesia has a negative impact. So there's a lot of potential upside to employing regional anesthesia with very little downside. We should also not overlook the fact that neuraxial blockade in particular has been shown to contribute to enhanced recovery, particularly in thoracic and abdominal surgery. And this will actually contribute to improved outcome by allowing patients with cancer to engage in adjuvant therapy earlier after their surgery, and also placing them in a better physical condition to tolerate the rigors of this treatment. Now, if we want to provide regional anesthesia for thoracic and abdominal surgery, the traditional method has been to perform a thoracic epidural. And in regional anesthesia circles, however, a currently popular debate is whether or not these epidurals have been superseded by fascial plane blocks. It certainly seems like injection into the muscular wall of the chest or abdomen should be preferable to putting a needle into the spine. But frankly, the answer isn't clear-cut, which is why these debates continue to feature in various conferences. I don't have a lot of time to delve into the pros and cons of both, but I'm going to say that I'm very much a supporter of thoracic epidurals in the right context. And this is because there are clearly proven benefits to patients. A working epidural is still the gold standard for analgesic efficacy in terms of reducing both the intensity of pain as well as opioid consumption. It has also been shown to reduce the surgical stress response effectively. You get this bilateral somatic and visceral analgesia that can be accurately targeted to the surgical area. And the opioid sparing that results minimizes the risk of adverse effects, notably nausea and vomiting and intestinal ileus, which will accelerate recovery. There is also good animal and preclinical evidence for improved splanchnic perfusion and gut microcirculation, so much so that in ICU, our colleagues are investigating thoracic epidurals to treat acute pancreatitis. Now, having said that, if we look at overall postoperative mortality, again, the evidence is less clear, But once again, the question is only whether there is a benefit or no benefit. It does not actually increase mortality in any study. In fact, it will reduce the risk of major morbidity, particularly for respiratory complications or cardiac arrhythmias. It also isn't as dangerous as we're led to believe. Here are three large database studies of thoracic epidurals that are looking specifically at associated complications. And all of these came from European teaching hospitals that performed a high volume of epidurals, but where you had trainees as well as consultants performing the blocks. And it's reassuring to note that only one case of permanent neurological deficit was reported. And even this was a dysesthesia sensory change in the inguinal region that was of unclear etiology. So if we pool the numbers, that gives us an incidence of just 7 per 100,000. The risk of transient deficits is somewhat higher, 2.4 in 1,000, but again, these are all sensory in nature and resolved within several days. Epidural hematoma in the elective setting, I will say, is much less common in thoracic than lumbar epidurals, with only one case reported out of these three studies, giving us again a pooled incidence of 7 in 100,000. Epidural abscess is a equally rare complication, and again, all of the three cases that were reported here were associated with catheters that were kept in place for 5 days or longer. Accidental dural puncture in one of the studies occurred in 7 in 1,000, which sounds high, but again is lower than it would be with lumbar epidurals. What's interesting to note is that none of the patients had neurological deficits or post-dural puncture headache. Perhaps, though, the most common objection to thoracic epidurals is that it results in hypotension. I would say, however, that I think this is a question of mindset, education, and appropriate management. So I've said that thoracic epidurals are being used even in ICU, and here, in these critically ill patients, the observed incidence of hypotension with thoracic epidurals was only 8%, and all responded readily to treatment with fluid boluses and vasopressors. The final question is, does this analgesia come at the cost of impaired mobilization? I would say that lower limb weakness is rare with thoracic epidurals, particularly if appropriately low concentrations of local anesthetic infusions like 0.2% ropivacaine are used. And there's no increased risk of falls compared to general anesthesia alone, as was observed in one review of more than 40,000 patients. What has happened is that thoracic epidurals have gained a reputation as a challenging technique with a high failure rate. And in this one 2016 article suggests that in training centers, at least, the primary failure rate, which is the failure to place the catheter in the epidural space, was as high as 20 to 24%. But I think that, again, we might be exaggerating this somewhat. Remember that thoracic epidurals provide bilateral coverage with a single puncture in a single catheter, unlike abdominal wall blocks. So it's actually less complex, perhaps, than trying to insert and maintain multiple fascial plane catheters. And if you have proper technique, a good understanding of vertebral anatomy, and you've been trained well, then the studies demonstrate that it can be successful 99% of the time, not 80% of the time. I do recognize, however, that there's this vicious circle of declining popularity and inadequate opportunities to practice and learn the technique. But speaking as somebody who now only occasionally inserts thoracic epidurals, we fortunately have other strategies that can be used to improve your success, and includes the use of ultrasound imaging and also confirming epidural catheter placement with stimulation and waveform analysis. I do describe ultrasound imaging of the thoracic spine for epidurals in a separate YouTube video, but very briefly, ultrasound lets us visualize the flat plate-like thoracic lamina as almost horizontal hyperechoic lines, with the gaps between these flat hyperechoic lines representing the interlaminar space. And within those gaps, you can see certain hyperechoic elements that represent either the bony lip of the lamina or the ligamentum flavum. And what this information from ultrasound therefore tells you is where these thoracic interlaminar spaces are located, where you want to place your needle, how deep they are from the skin, giving you reassurance that you're not going to go too far before getting into the cord, and also where the midline is. And if you mark this information on the patient's skin, it will let you more accurately triangulate your needle insertion. In patients who have scoliosis or degenerative disease, the older patients, you can also determine if certain spaces are more open than another one. But regardless of whether you use ultrasound or not, I think it's important to make sure that you adopt an appropriate insertion point and trajectory. And for me, over the years, this has meant staying very medial and close to the midline, just alongside the spinous process, in keeping this lateral to medial angle small. By doing this, you limit your redirections to just one plane, so cranial and caudal, which will reduce your error and increase the chance of success. I therefore greatly prefer to refer to this not as a paramedian approach, but a paraspinous approach. And I believe this is actually what's happening when we perform what some people would call a midline thoracic epidural. When you are inserting it, though, the needle entry into the epidural space for all of us is usually confirmed by feel of ligamentum flavum and loss of resistance to saline or air. And I think all of us acquire this feel with our training in the labor and delivery suite. It can sometimes be unreliable, though, particularly in the thoracic area. And so we've seen the development of methods to confirm where the catheter tip is actually lying within the epidural space. And there are two methods with proven benefit, which is epidural stimulation and waveform analysis, which I'll briefly discuss here. Epidural waveform analysis requires that you have a pressure transducer kit and a length of sterile tubing to connect it to the hub of the needle. But this is essentially an arterial line kit. So I think it's accessible to almost everyone. You just have to think about using it. And once you've connected this, the presence of a pulsatile waveform will indicate that the tip is lying within the epidural space. So in one RCT, where thoracic epidurals were performed by residents, the group that used waveform analysis had a significantly reduced epidural failure rate. And you note that they had a very strict definition of success, which I think makes these results all the more remarkable. The time to complete the block was slightly longer in the waveform analysis group, but it's worth noting that using that waveform analysis led to reattempted insertion in 40% of the group. And although we don't know if all of these would have been actual failures, I think it probably did contribute to the overall success rates in that group. Now, epidural stimulation using a specialized epidural kit was also described by Bansui quite a long time ago. Since then, a special adapter has also been developed that can be used with a saline-primed regular epidural catheter to conduct current. And epidural stimulation is particularly useful for ensuring that you've placed your tip at a desired segmental level. Essentially, you'll see a motor response in the truncal muscles at a current threshold anywhere between 1 and 10 milliamps if your tip is lying within the epidural space. Anything outside of these limits suggests that your catheter tip may be somewhere else. This recent editorial from the CJA highlights the utility of epidural stimulation, but I will say probably that the obstacle remains the need for this specialized equipment, either the adapter or the stimulating catheter. But one solution that I've seen in some centers is to use a stimulating peripheral nerve catheter, which is very similar in design to epidural catheters as the epidural catheter. So going on, the final area in which I'd like to highlight the value of neuraxial blockade is orthopedic surgery, and particularly in total hip and knee arthroplasty, which is extremely common worldwide, given that we have an aging population and prolonged lifespan in almost all countries. And these surgeries can be easily done under spinal anesthesia. But it appears that whether or not you do get a spinal or a general anesthetic may depend more often than not on the country, the hospital's culture and preferences, and those of the anesthesiologists. The data from the US in particular makes it appear that general anesthesia is much more common. This, however, is unfortunate because I think it's quite clear from multiple large retrospective reviews and randomized controlled trials that neuraxial blockade is actually associated with improved patient-centered outcomes. So this 2019 article presents consensus recommendations from a large international group of experts and is an excellent summary of the current evidence that's available. I've summarized the main findings in this table here, and you will note particularly that spinal anesthesia reduces mortality risk after total hip replacement surgery. There wasn't the same significant difference in mortality in total knee replacement, but you'll see that the rate of many of the same major complications is much lower when you use spinal anesthesia. Most of the major organ systems are represented, as you can see. The only downside to spinal anesthesia, as we've previously mentioned, was this increased rate of urinary retention. What is equally important to note is that there were no outcomes for which general anesthesia has ever been demonstrated to be superior. To be fair though, total joint replacement is pretty safe, as you can see from the estimated incidences, which makes the absolute risk reduction relatively small. But nevertheless, I think given the volumes of joint replacement surgeries that we do worldwide, there is clear benefit from spinal anesthesia with very little downside. And according to one estimate in the US alone, we're looking at 1 million total hips and 4 million total knees each year by the time we get to the year 2030. The mechanisms for the benefit of spinal anesthesia are not entirely understood, but the major factors that I believe to be relevant include avoiding alterations in lung function that occur with positive pressure ventilation, and increased organ perfusion from the vasodilatation that is produced. And while we often associate spinal anesthesia with hypotension, as I've said again, in reality it's actually been found to be less common because we're probably very vigilant for it, and it's easily managed with vasopressors and adequate fluids. So I think all in all, there's a good case for spinal anesthesia being the routine approach and even standard of care in modern joint replacement surgery, especially hip replacements. What about hip fracture surgery then? This is also a very common cause of significant morbidity or mortality worldwide. And can spinal anesthesia improve outcomes in the same way that it does for hip replacements? This has been a question that has been and continues to be intensively studied. And some of the best data and research on the subject has come out of the UK, which, as I've shown you with regards to joint replacement, is generally speaking more pro-neuraxial blockade than the United States. Yet in this audit of surgical cases performed in England and Wales in the year of 2012, we'll see that general anesthesia was actually a relatively common choice, perhaps even more common than neuraxial blockade. Unfortunately, unlike total joint replacement surgery, we don't actually have a good answer yet to the question of whether spinal or general anesthesia is better. Almost all studies to date, and that includes systematic reviews, large observational studies, have not found any difference in mortality associated with the use of spinal anesthesia. The one exception, though, was in Korea, which reported a statistically significant but perhaps clinically marginal difference in mortality, a reduction with regional rather than general anesthesia. But as with the total hip replacements, what has been noted is that spinal anesthesia may be associated with a lower risk of blood transfusion and urinary tract infection. And this was demonstrated in a propensity matched database analysis from Nottingham in the UK over the period of 2004 to 2015. But we have to be a little bit cautious in interpreting retrospective studies when we're trying to establish causality, because you'll see here too that the same group reported that the rate of chest infections was higher in the spinal anesthesia group. It seems very much counterintuitive, and you might ask how this can be. Well, it turns out that there were twice as many patients with COPD in the spinal anesthesia group, which isn't that surprising because most of us would view that as an indication for attempting spinal anesthesia. But the fact that they have COPD places these patients at a higher risk of chest infections, regardless of whether they're intubated or not. And it's not by virtue, it's purely by virtue of their disease. Bearing in mind what I just said about not confusing association with causality, I still think it's worth noting that when they perform a subgroup analysis of the cohort in Nottingham who had cardiovascular disease, which was a majority of the patients, there was actually a statistically significant decrease in 30-day mortality that was associated with spinal anesthesia. Some of us also favor spinal anesthesia in the hip fracture patient because we believe that avoiding general anesthesia may reduce the risk of postoperative delirium, which I've talked about already. And this same Korean study was able to observe a statistically significant difference, although it's perhaps not as large as we might hope for. Now, one explanation again could be the sedation that's often combined with spinal anesthesia, which if we're not careful can be as deep as a general anesthetic. I discussed the findings of this STRIDE trial on depth of sedation in hip fracture earlier on, and you'll remember that although there was no overall difference in the incidence of delirium, healthier patients did benefit from a lighter level of sedation. So I think that definitely less is more in this case. So to sum up, hip fracture patients are medically complex, and it's likely, again, like with cancer, that many factors apart from the type of anesthesia are going to contribute to the outcome. And old song says, maybe it ain't what you do, but the way that you do it. And certainly avoiding a delay in surgery is a critical factor. So we as anesthesiologists should make sure that apart from the type of anesthetic, we need to play our part by trying to expedite surgery, not insisting on excessive workup and investigations. And one of these issues is related to the patient on anticoagulant therapy, which is an increasingly common scenario that we all face. In my institution, at least, surgeons are willing to operate earlier than most of us would be prepared to do a spinal anesthetic according to the ASRA and ESRA guidelines. What's quite interesting to me is that this issue has been recognized by the Association of Anaesthetists in Great Britain in their 2020 guidelines on hip fracture management. They've recently recommended a pragmatic and quite aggressive approach if spinal anesthesia is truly indicated. So Shelton and White in their review suggest that antiplatelet therapy is not an absolute contraindication, even if it's clopidogrel, and that you could even consider spinal anesthesia in patients on direct oral anticoagulants who have normal renal function within once you have exceeded 2 half-lives, whereas usually we recommend waiting 4 to 5 half-lives. And this is based on the fact that when you look at the data, the risk of hematoma with spinal anesthesia is very low, much, much lower than it is with epidurals. So where spinal anesthesia seems to offer a definite benefit, then that risk may be actually worth taking. I do recognize that this is certainly a recommendation that not everyone will be comfortable with. I'm not even sure that in my own setting, this would be widely supported. So I do advise considering that your local practice environment before you incorporate this into your practice. Regardless of whether you choose to perform general spinal anesthesia though, it seems to be a good idea to avoid intraoperative hypotension. The lowest systolic and mean blood pressure recorded during the surgery has been shown to correlate with both 5-day and 30-day mortality, and is thought to be related to organ perfusion, organ hypoperfusion, I should say. So where does that leave us? I'm going to offer my personal opinion, recognizing that I am an enthusiast of regional anesthesia, and that is that spinal anesthesia is an appropriate first-line option if it's feasible and does not in itself delay proceeding to surgery. There's an overriding theme in this talk, which is really that neuraxial blockade offers lots of potential benefits with very little downside. And certainly the surgical similarities, I think, make it reasonable to expect to see some of these advantages that we observe in total hip arthroplasty in hip fracture repair surgery as well. And these benefits are likely to be maximized by attention to simple things like maintaining normal tension during the surgery and using minimal sedation. If you do decide to incorporate spinal anesthesia into your practice more, I think the issue that you may find is making your spinal anesthesia work consistently well, particularly in the older patient who will have degenerative disease and deformities of the spine. It's quite different from the young obstetric woman coming for labor and delivery. Now, there are two main categories of neuraxial block failure. One is technical failure, and the other is therapeutic failure. I think therapeutic failure is the easier one to address because it's largely due to the dose of local anesthetic that you administer and the factors that govern distribution of this local anesthetic within the central cerebrospinal fluid. The most important of these are the porosity of your local anesthetic solution and the positioning of the patient when it comes to spinal anesthesia. With regard to technical difficulty, I think there are only a few reasons for this. These are listed here. But the good news is that there are ways to address all of them. There are three things that I personally believe are critical. One is good fundamental and needle handling technique, which I've described in 2 videos on my YouTube channel, and I try to impart to the residents that I teach. The second is having a detailed knowledge of the anatomy of the spine. And the way I describe it to the trainees is that if you do contact bone on needle insertion, you want to be able to say what bone it is that you're contacting, what part of the vertebra. Is it spinous process? Is it lamina? Is it facet joint? And that will allow you to make this logical and reasoned redirection attempt that will eventually walk you into the space. What you're trying to develop is this 3D mental model of the spine in your head. And the third thing, which will actually help you with developing this 3D mental model, is to acquire the ability to do ultrasound imaging of the spine, which will actually allow you to see that underlying anatomy and locate the interlaminar spaces. Now, while I could happily spend several more hours taking you through this, we just have the time to give you a brief idea of what it involves. And I encourage you to refer to my YouTube videos that cover this in more detail, ranging from basics to how to employ them in more challenging patients, and then to invest in practicing the skill in your day-to-day work. But briefly, the aim of spine ultrasound is to obtain a series of these 2-dimensional views of the bony contours of the spine, with the underlying principle that if we can identify a soft tissue window that allows the ultrasound beam to enter the canal, then that same window will allow the passage of your block needle. As I've said, ultrasound imaging of the spine requires a sound knowledge of vertebral anatomy and a degree of pattern recognition, but this really isn't difficult to acquire. There are 2 basic views. First, the parasagittal oblique view, in which we direct the ultrasound beam through the paramedian interlaminar space. And we get this characteristic sawtooth-like pattern, which are the laminae of the lumbar vertebra. The gaps between these saw teeth allow passage of the ultrasound beam and reflects off the anterior wall of the canal, producing what we call the anterior complex. And between the saw teeth themselves, we'll see the hyperechoic structures of the ligamentum flavum and the posterior dura, which we call the posterior complex. We use this view most often to identify and count the interlaminar spaces, and also to assess the ease of a paramedian approach. The second one is a transverse view, in which we will either see the spinous process, which is recognizable as this tall acoustic shadow cast by the bone that looks somewhat like a church steeple. And then if we shift the probe cranial or caudal from this location, the beam will now enter the interspinous space and penetrate into the vertebral canal, where again, we should see the anterior complex of the anterior canal wall and the posterior complex of the ligamentum flavum and posterior dura, with the intervening intrathecal space that's filled with CSF. We use this view to make skin markings to guide a midline approach to lumbar spinal epidural anesthesia. And this brief video will illustrate the process in its entirety. So you do this as a pre-procedural scan, placing the ultrasound probe here in the transverse position. We can see an anterior complex. And you make small sliding and tilting motions to try and get the best possible picture. You want to see that anterior complex popping out of the shadow of the acoustic process, acoustic shadow of the spinous process. And once you've got a good image, on clean, dry skin, you can mark the midline. You mark where the beam is coming out, which is where that interlaminar space is going to be located. You can reinforce these marks to make it more clear. If you're worried about tattooing, don't extend the marks into a crosshair, but you'll see here that provided you've made the marks on clean, dry skin, not through gel, those marks will actually stay in place to guide you during a subsequent attempt. And with a little bit of practice, you'll find that putting the needle where you've visualized the space will get you into a successful epidural spinal with minimal needle passes. I know some of you are thinking that clearly that particular patient did not need ultrasound to have a successful spinal anesthetic, and I will admit the conventional landmark guided technique would have worked just as well. So ultrasound doesn't really have a place routinely in patients who have good anatomy and if you're a skilled operator. Where it is of value is that it is an advanced skill that you would use when faced with challenging patients. Just like we don't use fiber optic bronchoscopy in everybody that comes to have an intubation, only in patients with challenging anatomy. But just like these advanced airway skills, this is something that we need to practice first on easy subjects. And if you invest time in that, then I guarantee you that ultrasound would transform the distribution of the difficulty of neuraxial blocks from this into this. So this next video is a good example. And I will say it was taken as part of a study in patients with poor surface landmarks, which is why the poor patient was allowed to be subject to this procedure. So you can see in the absence of easy palpable landmarks, the poor trainee that was the subject of this study didn't quite know where they should be directing their needle. And also that most of those redirections are being done in a rather non-systematic approach and are ultimately not particularly helpful. In particular, because this patient, appears to be slightly obese, we're not even sure if we were able to reach the space with a regular needle, which is something ultrasound would have told us. So here we are, resorting finally to using a longer needle. However, there's still no joy. And so after the predetermined time of the study, we resort to an ultrasound rescue. And you can do this if you run into trouble. Use an ultrasound probe with a sterile cover to image the vertebral canal and the transverse view as I've previously shown you. And that allows you to identify the midline and the interlaminar space. Mark this on the skin. Here I am just making some small adjustments to be sure that I'm absolutely accurate. And this is where the practice comes in, that you're able to really accurately mark the location on the skin. And thereafter, the rest of the procedure is very straightforward. Again, as I've said, this is a pre-procedural process. So when you're actually doing the spinal, I still use all the same tips and tricks that I would use otherwise, including fixing the skin, feeling what I'm contacting, looking for resistance to injection as we enter the interspinous ligament. Here I am just walking off the spinous process. There's that resistance to injection, which tells me I'm in the midline. This handling of a long, flexible needle is another example of paying attention to good fundamental technique. But there you are. So, really to sum up, there are three main indications that I personally use ultrasound imaging for nowadays. First, if I really want to know where I'm going, so some patients who have, say, disc prolapses, and I want to be at a particular intervertebral level, or if I want to give patient the first-class treatment and make sure that I get in one pass. Second is if I think I'm going to have some trouble, and the third is, as I've shown you, if I need to get out of trouble that I failed to anticipate. So this last video, which I recently posted on my channel, is a good example of using ultrasound for anticipated difficulty.
The case in question was an older gentleman undergoing elective total hip replacement surgery with a plan for spinal anesthesia. He had never had a spinal before and had no overt contraindications to one. But on history taking, he mentioned that he had a scoliotic spine and degenerative disc disease, although he was presently asymptomatic and had been told that no surgical intervention was required at this stage. The patient, however, did not have a very obvious scoliosis when we sat him up, with perhaps the only clue being his tendency to lean slightly to the left. As is common in many slightly heavier patients, the lumbar fat pad made palpation of the spinous processes difficult, and it was thus difficult to establish the deformity with just clinical examination. A later review of his old x-rays showed that he did in fact have quite a significant scoliosis, with a convex curve to the left at the lumbar spine. Time to get out the ultrasound then. Placing the probe in the left parasagittal view, we obtain a good view of the L5-S1 space, which is immediately reassuring. This is what I refer to as my get-out-of-jail-free option. The L5 to S1 space is almost always open when the other spaces are closed. I use a mix of plain bupivacaine diluted with sterile water, which is significantly hypobaric, and in my hands at least, removes any concerns about adequate block height for hip surgery. Sliding the probe cranially, we see a narrower L4-5 space, but then something peculiar happens. The sawtooth view of the lamina disappears, and we instead see a tall dropout shadow, which is a spinous process, in this case that of L3. This is a clue that the patient has a lumbar scoliosis. As the probe was slid cranially in a vertical line, instead of visualizing each lamina in turn, the spinous process enters the beam instead, as the spine curves, to the left in this case. If, however, we slide the probe to the left at this point, the beam will once again now enter the paramedian interlaminar window and give us a view of the anterior complex of the L3-4 space. Note, however, that to obtain this view, the probe does not have to be tilted towards the midline as is usually necessary. This is because of the rotational scoliosis that always accompanies the lateral curvature. This rotation allows the ultrasound beam to enter the canal in a strict parasagittal plane without the need to angle obliquely. So parasagittal imaging with the ultrasound has allowed us to independently confirm the presence of a lumbar scoliosis with a convex curve to the left. This is further verified by turning the probe transverse and visualizing the spinous process shadow. When we do this, we can see that the spinous process shadow is tilted and not perfectly vertical. Rocking the probe to point it towards the left shoulder will return the shadow to the vertical. This is in accordance with the Bovex rule. The vertebral body always rotates towards the convex side of the curve. In this case, you can actually see to the L4-5 space through the midline as evidenced by the anterior complex. However, it is a narrow window. It would be better to target the large paramedian interlaminar window that we identified at L3-4 on the left convex side of the curve. In sliding the probe up to the L3-4 level, we can clearly see an anterior complex to the left of the spinous process shadow. We can center this anterior complex on the screen and mark its position on the skin. If the ultrasound beam can penetrate to image the anterior complex, then the needle will be able to follow the same trajectory to enter the vertebral canal. Local anesthetic infiltration should occur without any resistance as the needle is passing through paraspinal muscle and not the interspinous ligament. Because of the rotation of the spine, the needle can be inserted without any angulation to enter the vertebral canal using a paramedian approach. Here we see our first-year resident using the imaging information and marks to successfully perform spinal anesthesia in a single pass. The spinal needle passes through paraspinal muscle to engage the ligamentum flavum and eventually enter the intrathecal space.
So I hope that illustrated for you quite nicely the value that ultrasound provides. You know, it allows you to really appreciate that anatomy under that skin, which you can't always tell from just looking outside, and it guides you as to the appropriate approach that you should take. But you can see that where the practice comes in, you need to understand those different shadows and patterns that you're seeing and what they mean as you move the probe around. But certainly it's a skill that can be acquired with just a little bit of practice, and it really has changed my practice over the years. I think ultimately the choice of whether you perform neuraxial blockade in your patient is clearly a balance of benefit versus risk, as it is for anything that we do. There are, as I've shown you today, clear benefits that have been demonstrated for major patient-centered outcomes in a variety of settings. And while the strength and quality of the evidences vary, as I've said before, it's very interesting to note that the overriding message is there are almost never any outcomes in which general anesthesia has been shown to be better than neuraxial blockade. The main obstacle to neuraxial blocks, in my opinion, is this perception of the complication rate associated with it, but that is lower than we commonly believe. And secondly, our perception of the difficulty that sometimes may be involved in performing it. Technical difficulty can be addressed with learning to use ultrasound imaging. And as I've said before, I think the overall data indicates that if you properly select your patients, neuraxial blockade is a very, very safe technique. I'll leave you with this thought from a letter to the editor that was written by some distinguished names in the field of anesthesia. And they certainly suggest that the balance is very much in favor of neuraxial blockade. Ultimately, though, the decision has to be an individualized one based on the patient that you're dealing with, your own skill set, and the circumstances that you find yourself in. Thank you very much. I think we'll move to a discussion. I hope that's given you some food for thought. And I look forward to the next 15, 20 minutes, and we can talk about things.
Thank you very much, Professor Chin, for an excellent talk. There have been a few questions that we picked up in the YouTube channel. I think we'll move to the Q&A immediately. And the first one, I think the first question was, are we really practicing spinal anesthesia in children and adolescents nowadays? Care to comment on that? So
I don't practice in pediatrics myself. And so looking at that article, though, I would say that what they were really talking about is spinals in infants, which again, I think most of us, unless we work in a pediatric center, are not going to do. Probably in that age range, though, outside infancy, certainly in the sort of toddler to primary school stage, you're probably not going to find that most children aren't going to want to have a spinal anesthesia. At that point, you can't really control them, so it doesn't really become an option. And similarly, I think adolescents are going to be fairly fearful of being awake and having a needle in their back. So I think in that instance, remember that we're probably just talking about infants, and we're talking about trying to prevent any deleterious effects of general anesthesia on the developing brain. I think it's an area that they're just trying to be a little bit provocative in making us think a little bit about it. But I personally would probably say that, adolescents and primary school kids, I think you'd probably still better off doing a general anesthetic. You can do a regional peripheral nerve blocks combined with the general, but probably most of them are not going to want a neuraxial block.
Okay. The second one, what is your opinion to perform thoracic epidural while patient is under general anesthesia?
So actually, an interesting story is the first one I ever did in my practice as a first year trainee was actually a thoracic epidural under anesthesia, and I actually got a dural puncture as well, which made the rest of the case very, very nerve-wracking for me. But the patient did fine. I think again you have to weigh risk-benefit. You have to ask yourself if you're comfortable in your skills, and if that thoracic epidural is really going to make a difference. It's one of those things where probably the reality of the safety is much greater than we think. But then we always worry if it's going to be defensible if something bad were to happen. I would say that I think most people are going to say that without a huge indication, that you may actually want to do rescue techniques. And this is where, again, then the abdominal wall blocks come in, I think. If you, for example, went from a laparoscopic to a midline open incision, after the operation, when it's closed, do rectus sheath blocks, rectus sheath catheters. Or the option is to do something safer like erector spinal plane blocks, which may provide some benefit. May not be as great as an epidural, but will certainly provide some benefit. So I think that the short answers to that is, I think most of us would probably try not to do it under general anesthesia.
Okay, agreed. The next question, what is your input? What are your thoughts about epidural anesthesia for laparoscopic surgery?
Epidural anesthesia per se. I have to say that I have never conducted surgery under epidural anesthesia, mainly because I struggle with the time taken to titrate in a surgically anesthetic block. I think depends on the type of laparoscopic surgery too, how much distension you're going to get. And if we talk about spinal anesthetic, right? You may have to get it very high. And once again, you might want to ask yourself why you need to do it. As I said, laparoscopic is very much about distension and abdominal relaxation. So you're going to have to induce a fairly high level of spinal anesthesia, probably up to T4, T5. And with that's going to come more issues with blood pressure management and the patient feeling quite uncomfortable, I think. So I'm not sure that is that feasible, but I am providing sort of theoretical considerations, not having actually done one before. Have you ever had to do it?
No, not really. But I think there have been a few publications, particularly with the lower laparoscopic, for example, the inguinal surgery and things like that. But I doubt, lap chole would probably be, amenable to epidural anesthesia.
Yeah, that's kind of what I was saying. I mean, if they're operating in the lower abdomen and if they're limiting insufflation pressures, then perhaps you could. But I think you'd have to discuss that very clearly with your surgeon and have a backup plan if the patient didn't tolerate it.
Mm-hmm. The next one, has there been any advances in continuous spinal anesthesia?
Well, again, not something that I have a lot of experience with. I was listening to a presentation at the recent EASRA about it. It seems that, the kits are available. Interestingly, they talked about even using a normal epidural catheter without too much risk in posterior puncture headache. I think it's one of those things that has remained fairly niche as an application, because again, I'm just theorizing here. I suspect that a lot of times now our modern surgery is advanced so quickly that we don't need to have this sort of duration that we would need from a continuous spinal. We can cover most things with a standard dosing of a spinal anesthetic. It might be something that you can do if you're really wanting to titrate in your spinal because you don't want to cause too much hemodynamic instability. But again, in practice, we've looked after some pretty sick patients, and we found, number one, that using a CSE is a good alternative, and that's something that I think all of us are comfortable with. And as I've said before, managing the hypotension that results or could result from the spinal anesthetic is actually quite easy. You place your arterial line before you do the spinal. Once the spinal's in, you just watch the blood pressure and you make sure you have your phenylephrine infusion or whatever vasopressor you like to use ready to go, and you can maintain stability in a wide range of patients. So I personally haven't found a need to sort of really push to incorporate CSA into my practice personally. What about in Malaysia? Do you think it's
I think it's I think the option for continuous spinal is mainly for very sick patients, with poor heart. I think we don't normally do it as a common practice.
Yeah.
The next question, Prof. Chen, is intrathecal morphine supplementation recommended for knee and hip surgery under spinal anesthesia? And maybe to add into that, can you share with what you do for your hip and knee arthroplasties, analgesia?
So it's a great question, and intrathecal morphine works. Okay, there's no doubt that it provides good analgesia for 12 to 24 hours. In our practice, if a patient is staying in hospital, then we do routinely add intrathecal morphine. Now, we use quite a low dose, 100 micrograms, because obviously the main risk that you'll be worried about, the main serious risk anyway, is going to be respiratory depression, which is dose dependent. And elderly patients who are probably going to be taking some opioid as well are more susceptible. So we tend to limit it to 100 micrograms. And we've done some studies and retrospective audits of our data, and it shows that it does make a difference. So it is part of our practice. It obviously shouldn't be given to anybody who's going home, because there's that potential risk for delayed respiratory depression with the intrathecal morphine. Similarly, the dose that you choose, as you go higher up in the doses, you're going to see more and more side effects, not just respiratory depression, but patients can get quite distressing pruritus. That has been something that we've noted, and nausea and vomiting to a lesser extent, but the pruritus is sometimes the most troublesome. But having said that, I've worked in places where we've given 200, 300 micrograms. I have friends in Korea who give 400 micrograms for abdominal surgery. And certainly in the UK too, there are people who are advocating for intrathecal morphine after abdominal surgery as an alternative to, say, epidurals. So coming back to the original question, hip and knee surgery, yep, if they're staying in hospital, adding a small dose, 100, maybe 200 micrograms of intrathecal morphine is actually a good analgesic option.
I think this question, is there any dose recommendation for spinal anesthesia for scoliosis patient? I think it's just, is there any difference in terms of dosing?
I don't think there is. I've been looking at this issue of adequate block height and things. What happens when we inject? You'd be wondering, is there a difference in the distribution due to the curves? I would say that only if you are using something that's very hyperbaric or hypobaric, you might want to think about whether, if you position them supine afterwards, do they have a severe kyphosis that's going to exaggerate pooling in one area or rising? But most of the time, we are just using the standard doses. We're not really adjusting it for the scoliotic patients. I would do simple things like, if it's a hip, I would just make sure that the hip is actually higher than the shoulders, that it's actually going to rise up to the area that I want, and I'll just eyeball it. But I won't change my dose necessarily. So I think it's more about the positioning afterwards and thinking about how the varicity of a solution is going to distribute if they have a really abnormal curve. I actually can't see the next question, which is...
Yes, I think that the last two questions are similar. Maybe you can answer them.
Yeah. So it's actually, most of the time, actually very easy, because if they had particularly laminectomies, then there is no bone in the way. And I think I have covered it in a YouTube video, but the ultrasound again is going to tell you. So instead of those saw teeth that you see when you look, you're not going to just see a continuous sort of train tracks of the posterior complex and anterior complex, because there's no bone in the way. And that tells you then that their entire canal is open. So spinal anesthesia is actually very easy. The one thing I will say is that here you probably want to use a Quinky or cutting tip needle, because there can be a lot of scar tissue, which is sometimes calcified. So occasionally I found that, when you try and use a pencil point needle, especially a 25 gauge, it feels like it's bone. But when you switch to the cutting tip, it'll actually go through. So I always use a 22 gauge cutting tip in these patients. Epidural, on the other hand, is different, because I think the space is obliterated. So I would be personally try not to avoid it, because I wouldn't be sure whether I'd be getting false losses of resistance or any loss of resistance before I enter the dura. But spinal, for sure, no problems.
There's this question by Ahmad Afifi. If in difficult spinal epidural, wouldn't it be better to have it done in real-time ultrasound guidance?
So that's been a question that we've dealt with as we developed and researched this. I will say that it's hard because, you know, you're trying to now line up three things, which is the small target of the small window between the bones, the beam, and your needle. You know, any of us who've done ultrasound know that it's quite difficult to see your needle on ultrasound because it's hard to bring the beam into the needle alignment. But now, every time you find your needle, you will lose your target. If you find your target, you'll lose your needle. And trying to focus on those three things is tricky. So, and again, with epidurals, you also have the issue of is it loss of resistance or not. Now, people have described various techniques to make it easy. I personally prefer to just focus on my marking and then thereafter to go by feel and the mental image that I have of the spine in my head. I have found that to be more useful. In the real time, I struggle with it, I have to say. But there are people obviously better than me at it, and it might be feasible for them.
I think it's probably not in the screen, but on the YouTube channel, low dose CSE or GA for patients with poor cardiac function. What is your practice?
I think if I have the option, if it's a surgery that's amenable to being covered by a CSE, I think a low dose CSE is fine. Like I said, I like the fact that the disruption of normal physiology is just one dimensional, right? We've got vasodilatation. If I have an arterial line, you know, we'll put that in and then we'll do the spinal and then we'll just give the vasopressors you need. So a great example that we often encounter is aortic stenosis. And certainly in my hospital, most of my colleagues will happily do spinal anesthesia for patients with, you know, up to moderate and sometimes even severe degrees of aortic stenosis if it's warranted. And we've had no problems managing them, just like I said, with the arterial line placed beforehand and a phenylephrine infusion. We also recently wrote up a case where we did a patient with a Fontan circulation who came for a total hip replacement. And that's quite interesting because, you know, we're now seeing these adult congenital heart patients surviving to the age where they're starting to need joint replacements. And in that patient, we actually did a CSE for her. We had a central line, an out line, and all sorts of vasoactive medications ready to go, but she was actually very, very stable throughout that. So, yeah, I think you know, neuraxial blocks are a great option because you don't have all these swings intraoperatively that occur as you stimulate them and not stimulate them, and all these different drugs that you give that change cardiac physiology in so many different ways.
I think we have a time for the last one. I think it's a similar question as above. Do you do spinal or epidural for those previously undergone spine surgery?
And as I said, not an epidural, but spinal for sure. But I would always use my ultrasound to tell me, because the other thing I didn't say is that there are different types of spine surgeries, right? They don't always take off all of the lamina, and sometimes they fuse the spine. Remember that people who have adolescent scoliotic corrections are quite different, right? They actually just have rods put in. They don't have any bone taken out. Whereas older patients who are undergoing decompressive procedures, they have bone removed. And those are the ones that usually have open canals. So if we talk about labor epidurals in the young woman who has previously undergone an adolescent scoliotic correction, those are still going to be tricky. But nevertheless, again, ultrasound will actually show you where hardware is. It may show you where spaces are. So that's a good solution.
I think, yeah, it's about time now. With that, I think we'll end the session. Thank you again, Professor Ki-Jinn, for an excellent talk. And I hope the participants, I have benefited in it, and hopefully we can take some of the pointers and may change our practice accordingly. I'd also like to thank Aspen for sponsoring the talk. I think, Prof Chin, would you like to say last few words before we end the session?
I'd like to thank you, Shah, for extending the invitation on the behalf of Malaysian Society of Anesthesiologists. I'm so pleased to hear that regional anesthesia is so vibrant and alive in Malaysia. I hope one day when the world returns to normal, that I'll be able to come back home and perhaps even pay a visit and see the kind of good stuff that you guys are doing there. But it's been a privilege to be able to contribute to the learning in this environment. And I wish everybody the best of luck with their practice.
Thank you again. Thank you everybody for attending, and thank you, Prof. Chin, for an excellent discussion.
Good night, everybody. Thank you for giving up your Saturday evening.